Welcome to today's Perfect Serve webinar, Creating a High Performance Practice. My name is Hilda and I will be your operator for today. We have just a few announcements before we begin. Please direct your attention to your computer screen as we cover the webinar platform functionality. Please note that you may need to zoom in and out of your browser to see everything. In the middle of your browser, you will see a box containing today's slides. They will advance automatically throughout the presentation. To the right of your slides, you will see a Q&A box to submit a question at any time. Your questions will be addressed during the Q&A portion at the end of the presentation. To the left of your slides, you will find a resource list containing a PDF of today's slides and a few other helpful resources. If you are on the phone line but are experiencing any technical difficulties accessing the web portion, please let us know by sending us an email to webinars@perfectserve.net. At this time, I would like to turn things over to today's moderator, Heather Dorsett, Director of Marketing with Perfect Serve. Heather, you may begin.
Thank you, Hilda. Welcome, everyone, to Perfect Serve's Thought Leadership webinar series. I'll be your moderator for today's event. Before we get started, just a few items to note in addition to what Hilda just went over. Today's webinar is being recorded for our friends and colleagues who are unable to join us, and you'll be able to access the recording later as well if you need to. As an audience member, you are in listen-only mode. So please make use of the Q&A box to communicate with our speakers or with me today. And at the end of today's events, we will ask that you complete a short survey that will appear on a separate browser window. And finally, we will be tweeting throughout the webinar, so if you hear something you like, tweet along with us. We'll be using hashtag #PSWebcast. You'll see streaming social posts located on the right of your screen under the Q&A. So for those of you who may not know Perfect Serve, we provide Perfect Serve Synchrony, which is healthcare's most comprehensive and secure clinical communication and collaboration solution. This webinar series is part of our ongoing promise to drive meaningful improvement in care delivery. We are so pleased to bring you our seasoned presenters like the ones we have today from Doctors Management. Valora Gurganious will be speaking with you today about creating a high-performing practice. And then Julie Mills from Perfect Serve will be talking with us about how Perfect Serve and Perfect Serve Synchrony can help streamline your communications within your practice. So we're excited to have these folks with us today. We will have a Q&A at the end of our presentation. But before we get to that, let me introduce our first speaker. Valora Gurganious is a senior management consultant with Doctors Management, a medical and healthcare consulting firm which has helped physicians with practice management in all specialties nationwide. Valora has 10 years of practice management experience and 8 years of investment management experience. She's also a vice chair of a multi-campus health system foundation in Florida. As both a certified healthcare business consultant and a Lean Six Sigma champion, Valora has prepared an excellent presentation for us today on creating a high-performing practice. And at this time, I'll pass things over to Valora to get us started. Valora?
Thank you very much. I appreciate being here and to speak with you today. I'd like to really lay out our agenda for this morning's presentation, and I will start with our learning objectives. First thing that we'll do is try to help you understand the drivers of practice performance. And that's really going to be a summary of many of the tools that we use at Doctors Management in optimizing our practices. Secondly, we'll seek to identify the opportunities and the steps that you need to do to optimize practice operations at your practice. And finally, I hope to leave you today with some takeaway tools that you can apply to your own practice to improve performance. I advanced a little further there. I will just mention here that the challenge for providers has really changed in today's healthcare environment. In the past, the physicians could do several things fairly simply to maximize financial success. They could give excellent patient care, efficient billing and collections, then follow with controlling expenses and building and maintaining a stable patient base. Today, the environment has changed. We now see physicians facing the pay-for-performance model. Of course, we now have MACRA, MIPS, PQRS, and all kinds of reporting standards. There are new treatment protocols that they must follow and comply with, and also the requirement for alternative payment models. So there's a whole lot of change going, and ultimately, of course, there's political change in Washington, and our physicians are working harder than ever with a great deal of uncertainty. Physicians are not only clinicians today, they also have to master the business of medicine. We start at Doctors Management by delivering what we call a practice assessment, and that's what I'm going to instruct you on today. And that's really to help you learn to be your own consultant. And the secret to that and to getting ahead in practice operations is getting started on that practice assessment. We begin by doing what's really a history and physical. Much in the same way that a physician approaches a new E&M encounter, we first run the diagnostics on the practice. We then assess the current state of the practice's health from a financial, operational, legal, and compliance, productivity, ancillary service, and revenue cycle management perspective. Once we've assessed all of those factors, we then craft a treatment plan. The goals of doing this history and physical are simple: to increase practice profits, improve patient satisfaction and outcome, enhance employee morale, but ultimately to reduce provider stress. First step in the practice assessment, we start by spending a great deal of time with the provider and the owner of the practice by clarifying their future goals. We really want to know where they'd like to take this practice and what's motivating them to do that. With those professional goals and animations, he doesn't seem to register here. You really have to start by knowing where you're headed in order to get there. Wendy, if you could help me advance here. It's not advancing my slides. Thank you. And we can head on to the next slide. With the professional goals and moderation, there are several things that may be motivating that provider or the group to set their strategy for the next 5 years. One of those might include an exit strategy if they're seeking to retire or sell the practice in the next 5 years. It may be horizontal, where they'd like to integrate ancillary services. It may be vertical, where they'd like to add partners or providers to the practice. Or it may be employment at a larger hospital or group. We spend some time really understanding what those needs and objectives are before we get going. That way we know where we're headed and how we're going to get there. Step 2 of the practice assessment, reviewing the financial performance and relative performance. We use such metrics as those from Medical Group Management Association, from the Healthcare Group, from National Society of Healthcare Business Consultants, and other resources to compare how the practice performs relative to other specialists in that same field and even geographically. We'll gather such information as 3 years of tax returns, profit and loss statements, balance sheets, and others, and prioritize basically to see where there are extreme variances from median performance, and then we'll drill down and really get to know what's going on within that practice that's driving that performance, either outperformance or underperformance. Step 3, spend some time evaluating their scheduling and their patient flow. We want to look at their patient volume versus industry benchmarks. We want to make sure that their practice management system is programmed properly. So some simple steps like making sure that the blocks of time for different visit types actually matches the time that the providers are taking with those visit types. We also want to look at patient wait times because that may also be a sign of problems and irregularities in their scheduling and even in the throughput time in getting patients addressed while they're at the practice. Look at how far patients are booked out and how new patients are worked into the schedule. All of those can be indications of dysfunction or errors in building their schedule and making sure the practice is optimized. When we're looking at scheduling and productivity, how are appointments scheduled? How are referrals taken? Some practices have a centralized scheduling and referral desk. Sometimes they do online scheduling or scheduling requests using ZocDoc or other online methods. How are patients registered? Are they using paper still in this practice? Are they using a patient portal or kiosk? And our charge is to really evaluate what they can be doing to streamline that process and reduce redundancy and make it a much more efficient process without repetitive steps by the staff. In doing a provider productivity analysis, we often do a provider time motion study. With that, it involves observing carefully while the provider is in clinic exactly how much time they're taking for various steps in the process. That goes back to the Lean Six Sigma process, is really breaking it down into a series of steps. We really want the doctor to always be operating at the top of his or her license. We want to delegate non-essential functions and non-revenue generating functions as much as possible. I see some physicians escort patients from the exam room all the way up to checkout. When you calculate how much time they're using to do those kinds of steps, it can be as much as an hour of time per day when you add it all together. I'd rather see them do things like documenting the encounter during that break between patients, placing orders or referrals, reviewing notes for the next patient, or responding to urgent messages or phone calls. That way they can really get out of clinic a lot sooner when it's time to do their documentation at the end of the day. I looked at a particular metric from MGMA to see, on average, how many patients per hour do different specialists see. Cardiology, 2 to 3, derm, 5 to 6, family medicine, 4, internal medicine, about 3.4, peds, 4 to 5, dental, 8 to 12. Of course, that's a little different because they have hygienists all working concurrently. Let's take a look at the internal medicine at 3.4 as the national average. With an internist, oops, just went a little further there, and one of the internists that I've worked with, we began doing that analysis of productivity by first drafting out the schedule. This particular doctor does 8 a.m. to 11:30 a.m. each day and 1 to 4:30 on Mondays, Tuesdays, and Thursdays. Wednesday afternoons, they do surgeries or hospital visits. Friday, administration time. So you see here over on the far right column, that's the number of patients seen on average per hour for that day. And the bottom line here in red, the doctor had 6.3 hours of clinic sessions per day on average, averaged 19 patients a day, and saw 3 patients per hour, pretty much in line with national standards. But that was not the provider's objective. We wanted to look at ways to increase that. Our goal was to get that from 3 patients per hour to 4 patients per hour. And the strategies that we pursued were as follows. We added a medical assistant who was trained also as a scribe to help screen or speed documentation. We involved a tablet, and we created templates in the electronic medical records to speed documentation. We revised the scheduling template with the staff and made sure that new patients were never grouped together. That was a problem for that practice. We also integrated the EMR to import labs and diagnostics directly into the patient record, and the medical assistant always confirmed that that was done the day before the visit, so if they needed to call, they had an opportunity to do that if the labs had not come in. Also confirm all appointments the day before the visit. That way, if there are any gaps, you have an opportunity to work those in and not have any missed opportunities or appointments where there are gaps in the schedule. But always make sure you verify benefits of those patients that are worked in. That's absolutely essential. We also created a sub-wait area for workups for vital signs and et cetera, making sure that you are keeping patient privacy in mind, but that keeps the exam rooms freed up for the provider consultation. We want those exam rooms always filled when there's a provider involved. So as much as possible, remove some of those preliminary workups to a sub-wait area and have them done there, and then the patient can wait for an exam room to open up. Can you advance, please? Thank you. The impact of the workflow revisions were, before the revisions, the physician saw 6.3 clinic, they worked 6.3 clinic hours per day, saw 3 patients, which averaged 19. After those revisions, they were still working the 6.3 clinic hours per day. We moved that up to 4 patients per hour, which brought them to 25 average patients per day. There's ways to work smarter, not harder, and what that meant per week is an additional 24 patients per week, with many of those being new patients and an average $100 collection per patient. At 48 weeks worked, that's an extra $115,000 per year. Even taking off 55% overhead, which is about typical for internal medicine, still the doctor is net profiting $52,000 at the end of the year, just with some minor tweaks to their workflow. Consider also adding a non-physician provider for even greater impact. I show here a chart that just shows you the difference between nurse practitioners, physician assistants, or physicians if the practice is considering a vertical expansion. Down at the bottom, you see the average base salary for nurse practitioners and PAs are fairly consistent with one another. You'll see the percentage in primary care, if that happens to be your group's specialty. 70 to 80% of nurse practitioners are involved in primary care. Only a third of PAs are involved in primary care. Only a third of physicians are involved in primary care. PAs tend to be more highly represented in the specialties like orthopedics and others. But the salaries, $89,000 for the non-physician providers, $173,000 for a physician. This is important because if your physician's considering expanding, they can really much more efficiently add that productivity and capacity with a nurse practitioner or a physician assistant much more effectively. We're going to take a look at that. The non-physician provider can improve patient access and outcomes. They're obviously providing access to care, especially in underserved communities. Many communities have now approved the ability for non-physician providers to provide independent care, independent of a supervising physician. So we're seeing more and more states add that, particularly under the ACA, as they look to make care more accessible in rural areas and even in inner cities where there's a lack of physicians. They also have higher patient satisfaction scores than adding physicians and a much lower cost of care. In the case of that primary care physician that we were talking about, here's the schedule. The morning and afternoon just represented by a little X there. When the physician was in clinic, And when the non-physician provider was in clinic, you see the physician was in clinic a total of 8 sessions per week, the non-physician provider 10 sessions per week. Patient daily volume I show here, before the non-physician provider was 30 per day. It went up to 50 per day that they were able to see once they added a mid-level provider. All the way over for the daily average, the average clinic in red here, 19 per day with the physician alone, 39 per day when the non-physician provider was added. So almost 100% increase in patient volume that they were able to see by the addition of that additional provider. Ultimately, that can nearly double the patient panel for an additional $1 million in practice revenue. And at that 55% overhead, you can look at, and taking out salary and benefits, which could be around $100,000 for a non-physician provider, the net practice profit, even after overhead, can be as impactful as $350,000 per year. Quite substantial. When you're considering, you can also consider adding ancillary services. When you're looking at ancillaries, you first need to look at legal issues. There are Stark laws that designate certain designated health services, or DHS, and these can fall into the categories of diagnostic testing, physical therapy, lab services. All of those things can qualify as in-office ancillary services. The only thing you have to do is make sure you disclose. You must give in writing to your patients that they do have the option of selecting a provider of that service outside of your practice, and you should even list who those are if there are other practices or service providers of that ancillary in your area. You're supposed to let them know, and they have the choice to use yours or to go to an outside vendor for that. Other DHS issues and legal issues, you could qualify as a group practice and meet billing, supervision, and location requirements. I usually recommend that you consult with your attorney, your healthcare attorney, just to make sure that there are no legal issues associated with your adding those under Stark. Then you also have to consider the practical issues. Does the provider or the staff have the proper certification and training to offer this new ancillary service? And is there sufficient treatment space in your office for that service? Have you made sure that your liability coverage covers to this extended service? And do you have enough money to make the investment if there's new equipment required? And is there sufficient demand? Do you have enough patients to refer for this service to make economic sense for your practice and even practical sense? Will you be able to keep it busy enough? In considering the ancillary services, think about what services you're referring out that you may now be able to handle in-house. Say in the case of internal medicine, maybe it's imaging, DEXA services, or some forms of x-ray, lab, therapies like physical therapy and others, or allergy therapy and things of that sort, specialty services, and supplies, certain kinds of DME. You do have to get clearance, however, before you pursue it. Before you pursue an ancillary service, here's a formula that can help you determine whether or not it's going to make financial sense for your practice. First, the category of equipment and supplies. The formula to use for that is the purchase price of that equipment with supplies divided by the estimated useful life in years. In most cases, you may use a 5 to 8 year time horizon for the estimated useful life before the technology, becomes obsolete. Then you want to add the annual cost of supplies and maintenance. All of that in total is going to give you that instrument's total annual cost. Then you divide that by the number of days or times that you'll use it per year, and this will give you the cost per day or times used, and that will help you determine, based on the cost of the supplies and the equipment, how much it's going to cost each time you turn that piece of equipment on or plan to use it. These next two formulas for staff labor and doctor labor is going to tell you how much labor cost goes into that ancillary service per hour or per minute used. Then the formula down in the lower right, time savings, is the doctor or staff costs per day divided by the labor costs per minute. That equals the minimum number of minutes that you need to save in order to justify the investment in this service. So quickly, you can plug in your own figures here and determine whether or not it's going to be a good return for your practice. The limitations of, there are certain limitations on what that break-even analysis will tell you. For example, if it shows that you won't break even until your 500th service unit, is that feasible? You have to determine, is that a reasonable period of time, or can you refer enough patients to that ancillary for 500 times before you will earn back at least the amount of money you invested? That may not be practical because it may be too long of a time horizon, or you may not have enough patients. If you do, you might want to reconsider if this is the right ancillary for your practice. If it may take a long period of time for you to recover and hit that 500 unit break even, maybe you want to lower your price or invite other providers to refer to your service, that ancillary service for your practice. But if there's no reasonable way of recovering those costs or predicting demand for that service, you really do need to look carefully at the service offering and your pricing very, very carefully. What the insurance payers are concerned about when providers offer ancillary services is overutilization. So before you do branch into an ancillary, audit your practice and confirm that documentation always lists medical necessity, because that's going to be the key factor in the event of a payer audit. Are you referring more patients to this ancillary because you have a financial incentive, or is it medically necessary? So really do drill down on your providers to make sure medical necessity has been established. You also want to make sure that income from that ancillary is distributed evenly, not on a pro rata basis based on the amount of volume a given provider has referred. That is where the insurance companies are concerned. They do not want there to be a commission paid for the provider who sends more patients to that service. It should be even, so it's blind, and there's no motivation for providers to send more volume to that service than is medically necessary. Alternatively, you can consider outside providers or vendors to provide that service for you. If you do subcontract those ancillary services, just know you can rent space in your office, and that vendor can bill for both the technical and the professional component. The only thing under this scenario that the practice can benefit from is if they rent that space out at the fair market value for that space. For federal patients, Medicare and Medicaid, the lease must satisfy lease exceptions, which means generally we ask that you investigate what the market value per square foot of rent is in your area, multiply that by the amount of square footage that that vendor will be leasing from you. That is all they are permitted to collect, or you are permitted to collect from them. You can only charge them that. There's no requirement that you refer to that vendor, and there absolutely should never be an inference that they will get 100% of your referrals from that, because that would be considered a conflict of interest. When you set a price for ancillary services, there are a couple of strategies that you can use. If it's a brand new or unique service, you may command a premium price. You could also command a premium price if the provider has demonstrated some specialized skill or some high high-quality outcomes. But if the service is available fairly broadly, you're going to have to be competitive with your other providers of that service in the area. You might even have to offer a little bit of a discount as an introduction since you'll be offering that service for the first time. Some examples of some new ancillary service lines, something like allergy therapy, which we do see offered in primary care as well as rheumatology and other practices, ENT and others. You can screen patients with a patient questionnaire by the medical assistant. You can subcontract through a vendor, and they can do the testing kits. Even the treatments can be subcontracted. And the provider will provide the assessment, and the non-physician provider can implement the therapy, and the practice can bill for the immunotherapy. So it can be a quite significant profit option for you. In the case of allergy, if you do use a subcontracted vendor, the potential income is anywhere from $70,000 to $120,000 per year. Often practices refer 3 to 4 new allergy patients per week that may enter the therapy. The cons is allergists have challenged insurance reimbursement for non-allergists in some states. They're trying to protect their turf, of course. And certainly for more complex allergies like food allergies, severe asthma, or other comorbidities, those should be referred to allergists. And once in a while, depending on your state, drops can require cash payments by patients, and those can be several $100s of cash, so some patients may not be receptive to the drop treatment, but it's an option for you. Another option for ancillaries is dispensary. Those are convenient. It improves patient compliance because they can pick up their antibiotic or whatever medication right in your office, don't have to go to Walmart or Walgreens to fill that. No on-site pharmacist is needed. You must file a form, typically by state. It's a fairly straightforward form to be credentialed to offer a dispensary. These are, again, for non-narcotic medications. You may have to purchase a software module, a barcode reader, and you have to have it stored in a secure, locked location inside your practice, usually also inside of a locked closet is what we recommend. For dispensary, the startup cost can be around $10,000 for software and starting inventory. After 6 months, you may have to pay the contractor to maintain and revalidate your insurance and restock your inventory. For the potential income, we typically see the practice netting $4 to $5 per prescription, which may end up with about 3 to 6 months for a break even. So if you do dispense quite a lot of prescriptions, it can make you some money. Radiography is another option, whether it's a DEXA scan or X-ray imaging. We do recommend that you double-check your regulations to make sure that if a radiologist overread is necessary, you've arranged for that, and you can typically pay a per-read fee to that radiologist for that service. Consider a refurbished X-ray, but make sure it is digital. Do not buy an old-school X-ray because you will not be paid for it going forward. The technical component would be billable by the practice if you're not a radiology practice. And say in a 4 to 5 provider, say rheumatology practice, you could make about $20,000 per year. But it is highly volume driven, so it definitely is contingent on the practice referring a lot of patients for that service to justify the cost. Medically supervised weight loss. We see the startup costs are very, very low. There are machines required to measure the BMI, body composition, metabolic rates. Often 5 to 20 patients per week could meet for group sessions, which can be supervised by a dietitian or a medical assistant with a monthly MD visit. Meal replacements can be offered, and the practice can make some money on those. and often one-on-one sessions can be available. Those can also qualify for telemedicine visits, which can pay you up to $25 for telemedicine consultations for patients who are on that. So it can be something that's very profitable and fairly easy to implement as well. The potential income for that, insurance doesn't pay very well. They typically pay $25 to $40 for a counseling visit, and for most of these programs, we see practices charging patients directly out of pocket. Those can range from anywhere from $1,500 to $3,500 for a full program, which would include the counseling and the meal replacement programs. Sometimes things like HCG shots or other kinds of pharmaceutical support for appetite suppressants, things of that sort. And the annual revenue could be $30,000 to $50,000 for a practice. Diabetes counseling. This goes well with the chronic care management. No real extra equipment is needed. Dietitians can serve as diabetes counselors, and they can bill through Medicare up to 3 hours of medical nutrition services per year. Some payers will reimburse for medical weight loss therapy for diabetic patients, but you do need a fairly large number of diabetic patients to offset for pretty modest reimbursements. And for patients who are not in pain or having neuropathy or other kinds of issues, they often no-show for the services. So just know they may start out fairly enthusiastic, but have a fairly high attrition rate over time. While you're building a more profitable practice, looking at those alternatives, don't forget to pay attention to your revenue cycle. We really spend a lot of time making sure you're collecting all the money that's due and you're collecting it in a timely manner. So that starts with a couple of key factors. You want to first make sure that you have an ICD-10 trained certified coder so that the documentation always matches the condition that the patient was being treated for, and you don't leave any money on the table that you would be eligible to bill for. You also want to verify eligibility, make sure all copays and deductibles are collected on the time of service, and that there's timely claim submission. We want to make sure that physicians and providers are locking those notes so that claims can be submitted ideally in less than 24 hours from the date of service. Also spend some time analyzing your EOBs and your aging reports, collections, and write-offs, because it may indicate that you have a coding problem. You may have verification issues because of looking at why claims are being denied. You'll see that there's a theme evolving, so it helps point you in the direction of finding solutions. Also make sure your staff is working those denials and that your fee schedules and contracts are reviewed each and every year. And you also have to be mindful of when you're eligible to renegotiate those fees, because the insurance payers limit the time in which you're able to renegotiate to sometimes 60 days before your annual anniversary and things like that. Next step is to do some operational best practices. Take a look at that handbook that the practice has in place for all employees. Make sure all employees have job descriptions and also get annual reviews. Make sure every employee has competitive wages and benefits. That will be quite telling, because you may find that the practice has a great deal of turnover, and possibly wages and benefits may be one of the factors making talent leave and go to other groups in the area. Does the practice hold regular staff meetings and encourage teamwork? Is there good customer service? And you can see that from their patient reviews, their Yelp reviews online, and other measures. Hopefully they're also sending out patient surveys, which will be a part of their PQRS measures in the future. So it's very important that the feedback is positive and strong. Also, make sure that the practice manager and the owners do a regular review of the practice financials. Often physicians don't know enough and perhaps the managers aren't always conscious of what factors are to make sure that the practice is on sound financial footing. It needs to have well-organized QuickBooks, payroll, P&L, and bank statements, know where all the money is at all times. Make sure there are checks and balances for cash, deposits, and payables, that there are things like a cloud backup of their electronic medical records, or if they are using a web-based system, that's probably already addressed by that provider, but they also have backup of their payroll and accounting in the event of a disaster. They should also have a manager evaluation and incentive program in place, but sometimes it takes an independent eye, like a consultant, to really tell whether or not the manager is doing a good job and is motivated properly to keep the practice on sound operational and financial footing. Then we want to take a look at compliance. There should be annual OSHA, HIPAA, and CLIA training and manuals for the practice. That is a new requirement. They should also make sure that they're ready and prepared for MACRA and MIPS. If they have not coordinated with their electronic medical records to do automated reporting, they should be registered with a registry and submitting at least 90 days worth of claims for that purpose. If not, they will face the penalties beginning in 2019. So the practice should be doing what it takes to get MACRA ready and MIPS ready. They should make sure that the EMR is secured and encrypted, and they have a backup on all devices, including cell phones and tablets that may be used within the practice, that they're audit ready. Sometimes it's difficult to know if they are or not without perhaps having a self-assessment. We do quite a few audits of practices to just make sure that they have a friendly face looking at their documentation and making sure they aren't at risk. So that kind of those kinds of analytics are really necessary to save you money on penalties or recoupment requests that the practice might get at some point in the future. So minimize that risk, look and see how you're doing, and if there are any course corrections necessary. Make sure that the charts are complete, notes are locked and up to date, including notes at the hospital by all the providers, and also that there are business associate agreements with all of the vendors that serve the practice, from their medical supply vendors to even their housekeepers have a business associate agreement, because those individuals will have access to PHI, and if they compromise the practice's PHI and disclose it, the practice is liable, whereas that business associate agreement will provide a bit of liability protection that they are now responsible for protecting that equally. The final step is to look at your practice's SWOT, the strengths, weaknesses, opportunities, and threats. You're going to do an assessment to optimize the business of medicine by evaluating the talent of the staff and the non-physician providers. We're going to look at scheduling so we can optimize productivity. We're going to look at ways to improve customer service. We're going to look at ancillaries that may be profitable, and we'll figure out some ways to track the return on investment for those ancillaries that we add. We'll finally ensure compliance and operational best practices, and strategize to shorten that revenue cycle and improve the quality of collections. Oh my, that skipped. Well, I think the action plan. We essentially want to determine the objectives of the practice owners, starting with the professional goals. Secondly, analyze the practice's financials and its relative performance. Thirdly, figure out ways to improve scheduling and improve patient flow and productivity. Fourthly, compute the feasibility of break-evens of the ancillaries and go ahead and implement them if they make the most sense for your practice. Then tighten those revenue cycle protocols, review regulatory best practices, and conduct that SWOT analysis. Of the internal medicine practice that I referenced earlier, by implementing many of these true consulting-based metrics, we were able to grow monthly revenues for that practice over 40%. That practice is now performing in the 90th percentile of their peers. They profit from ancillaries are up 70%. Eventually, they added a non-physician provider initially, subsequently added a second employed MD. They've joined an ACO as an alternative payment model, and they're coordinating care with other providers and, in fact, using a system very similar to Perfect Serve to implement that. And patient evaluations overall have improved. They're scoring very highly on the QRUR, which is Quality and Resource Use Reports, which is one of the measures under MACRA. The physician is happier, taking home over 30% more income, and can really foresee a more lucrative retirement in the future. That individual hopes to have the employed MD eventually acquire the practice, sell out, and then retire. So that's their goal, and we help them get there. I'd like to thank you very much, and I will now turn it over to my colleague from Perfect Serve.
Thanks, Valora, for that wealth of great information. I do see some questions coming into the Q&A box, but before we get to those, I would like to introduce our audience to my colleague, Julie Mills, who is going to spend just a few minutes sharing how Perfect Serve Synchrony can help improve efficiencies in your practice. Julie is a senior manager at Perfect Serve with over 14 years of nursing and informatics experience. Every day, Julie helps healthcare organizations like yours evaluate their communication complexities, identify strategic opportunities, and design solutions that work for their unique workflows and needs. Julie, thanks for joining us today, and I'll turn it over to you.
Great. Thank you, Heather. So as Heather mentioned, Perfect Serve Synchrony is a comprehensive communication and collaboration solution, and we work with both hospitals and physician practices. Actually, over 25,000 physician practices and post-acute communities use Perfect Serve in their offices today, as well as potentially in one of the hospitals where they're on staff, to help streamline and better coordinate communications with their colleagues. And so what Perfect Serve allows you to do is to have a personalized algorithm for your particular practice, how people communicate with you, and that helps more accurately route information to you, both in an after-hours practice setting or 24 hours a day for perhaps the hospital communications or outpatient referral communications. Route those in a way that is most effective for you yourself and the people that are in your group. It certainly brings efficiency when you think about being able to reach out to the correct person. So if you are in a primary care setting and you need to consult with a specialist, being able to reach out to that specialist through Perfect Serve is certainly a much simpler process when everyone's using the platform. So there are a lot of physician-specific benefits: speeding time to treatment, having a lot of access to your workflow right in the palm of your hand, and I'll show you ways that physicians can accomplish all of these things. And that's right there through the mobile application. So this is a picture of what a mobile application looks like for our physician and our non-physician providers that might also work within the practice. But they have a specific contact list of people that they can communicate with securely on Perfect Serve. They have that secure message inbox where they can attach images and audio files, share that information back and forth. They can also securely call patients or family members through the mobile application, and it disguises the caller ID of their cell phone automatically, and it inserts the caller ID of their practice, which can be a huge frustration sometimes for physician providers trying to communicate on the run. There's also a charge capture capability that I'll touch on more comprehensively here in a second, but helps with capturing those charges, again, right in the palm of your hand as you're seeing patients, both in the clinic or perhaps in the hospital. Your on-call schedules are incorporated, as well as any meeting statuses or things where you might need to communicate a little differently for a short period of time with other people. Administrators obviously see benefits from this as well. It allows them to customize their workflow processes and streamline those communications with both their patients and the providers in the community, as well as their internal staff, and making sure that they're communicating effectively with the right providers in a secure and efficient method. Maintaining HIPAA compliance is also a huge driver these days as well. And the way that Perfect Serve helps enable the process for these physicians and their practices is through our proprietary dynamic intelligent routing. So in each communication event, if you're reaching out to communicate with another person, oftentimes you don't automatically know who the right person is that you need to contact. And so in order to determine who that person might be and how they want to be contacted, there are a lot of variables that come into play, and Perfect Serve looks at each of these variables, like where is this communication originating from? Is this the patient, or is it the hospital, or perhaps another physician? Where are they located? Which patient specifically in an acute care setting might this be about? And what is the reason for the communication, the day and the time? Because we know coverage models shift and change during the day into the evening, night, and then on to the weekends and into holidays. And then once that correct covering provider is identified, what is their communication contact preference? Because we don't all prefer to communicate in exactly the same way, and Perfect Serve can provide that customization and that flexibility to each unique participant. And then obviously once the communication is sent out, maybe it's a patient calling into the office and this is going to the correct covering provider in the way they want to be contacted by a patient. But then there's also that return communication back, enabling that physician or PA or nurse practitioner to reach back out to that patient securely based on the callback number that's been entered, and protect the anonymity of the calling provider. So physician groups, whether they're employed or affiliated, certainly benefit from the management of all of the different types of calls that may come into the office. Some larger practices specifically that see a tremendous amount of call volume through using Perfect Serve in a 24-hour type of setting have seen large volumes of their inbound calls be rerouted directly to the correct providers and who needs to be covering for certain types of calls, which brings greater efficiency, and specifically for patient calls to be handled by the front desk. We do, again, offer an after-hours service as well as a 24-hour service. So, again, lots of flexibility and customization based on what your practice needs. And we do bring a focus to care coordination as well as some capabilities to help assist you with efficiency of charges, so that those charges that are so important for reimbursement purposes are collected quickly and accurately, again, right there in the palm of your hand, so you optimize your reimbursement. One of the capabilities Perfect Serve has is to hook into any billing system out there through our charge capture module, which is built directly into our mobile application. So again, it's right there in the palm of your hand. So as you are seeing patients in clinic or you're rounding in the hospital, you have all of these opportunities to manage each of those charges right there as you're rounding. And you, again, the customization, you can build in bundles or favorites and drill downs on certain diagnoses or ICD-9 codes so that you can most effectively use this module to suit your needs, specifically in your practice. So holistically speaking, Perfect Serve was architected in order to not just live within the practice or not just live within the hospital, but to comprehensively address all of the communication challenges that may exist uniquely within your practice, as well as the four walls of the hospital out into the post-acute community and pulling in your skilled facilities and your LTACs, those ACOs that were mentioned, building in all of those different puzzle pieces so that we can really assist with communication across the entire care continuum and help that transition to value-based care and bundle payments when your bundle payment doesn't just rely on what happens in your practice or within the hospital, but really it relies on all of the coordination between all of the pieces in those transitions of care. So we have a huge focus on helping providers in their practices and in their hospitals achieve success through this value-based care model that we're seeing come into play. And with that, I will open it up back to Heather with any questions.
Thanks, Julie. That's really good information and ties so nicely with Valora's content, so thanks for that. We do have a couple of questions. I'll start with one that came through, I think, Valora. This one would be good for you to answer. This is related to your comment about non-physician provider scenarios. There's a question about from a listener who says, we've been considering this. Are there certain practice types or sizes that work best for a non-physician provider scenario? What are the pros and cons for that?
We see them best applied in primary care settings, hence their 70 to 80% representation in primary care, pediatrics, even OBGYN to some extent. Practices that also have a great deal of chronic care necessary with, diabetic patients and others that require lots of ongoing monitoring or testing periodically. And there may not be an acute visit, but just ongoing maintenance of care for those patients. So where there is an opportunity to triage and have the non-physician provider there and determining what care plan is necessary. Of course, the physician needs to be on site to set that treatment plan, but the non-physician provider can implement the care plan once it has been established by the physician. So it's simply a way to improve productivity and that patient access to your practice. But primary care groups do tend to do very well with it. Even we see rheumatology practices using them for infusion therapy and other kinds of therapies. So they're very, very successfully deployed wherever you can see the opportunity to do that at a lower cost than adding another physician.
Okay, great. Thank you for that. We do have a little bit of time for one more question. Before I ask that, I would like to call your attention to our poll question. We'd love to hear from you if you would like some more information following this webinar. And while you're answering that, let's pick up on our final Q&A question here. Julie, this one is for you. This person says they've been considering replacing their answering service, but are not really sure. They've explored some options, but not really sure where to go. How does PerfectServe replace traditional answering service? Is there hardware set up? What's the implementation like?
Yeah, that's a great question. So PerfectServe has a pretty simple and straightforward approach to working with your practice. We are very hands-on. It starts with a discussion about what you're trying to achieve, what pain points you currently have, and what's important to you. And there's then a consultation around what the workflow process looks like. So during a certain time, if a patient calls in, what are the appropriate questions or what are the appropriate details that need to be gathered, what your on-call process looks like. And then we design a workflow process, again, around that dynamic intelligent routing to ensure that when patients call in, they have a straightforward experience that is productive for them. And it may be somewhat different for a healthcare provider or a hospital that's calling in. So we customize those pieces, design them, and then build them into the platform and allow you to test them. And in many cases, most practices can actually go live within 2 weeks.
Great, good. Thank you for that, Julie. We are at time, so that'll wrap up our Q&A portion. Before we part ways, I do want to let you know we have an upcoming webinar on April 11th, Tuesday at 1 p.m. Eastern, regarding handoffs and smooth transitions of care. There is a CEU credit for this for nurses, so if you have any nurses that you know of who would be interested in this, please pass that along. We'll be sending out invites shortly for that. Thank you to Valora Gurganious from Doctors Management and to Julie Mills from Perfect Serve for a really fantastic presentation today. And thanks to all of you, our audience, for joining us. We know your time is valuable and we appreciate you spending it with us. Please do take a moment to complete our short survey and tell us how we did, and have a great afternoon. Thank you.
Thank you, ladies and gentlemen. This concludes today's webinar. Thank you for participating. You may now disconnect.